You are listening to Hit Play, Not Pause, a feisty menopause podcast for active, performance-minded women. I am your host, Celine Yeager. Each week, I bring you advice from athletes, scientists, researchers, and other experts to help you feel and perform your best no matter what your hormones are doing. This show is a production of Feisty Media. Hello, strong, feisty women. I hope you all are well. So, as I'm speaking, I am thinking that this episode is really pretty timely. So I was putting together the show notes and all the assets that go into publishing a podcast, and I got a note from a longtime member of our community that she was bailing on a fun 3-day weekend she had planned with her friends because of pelvic floor issues. A few messages back and forth later, and I learned she's having persistent pelvic floor issues and now finds herself suddenly feeling like she's going to pee herself. And it's freaking devastating because I hear this far too often. Women who stop going to the gym because they peed themselves doing squats or deadlifts. Women who stop CrossFit because they pee themselves jumping rope. Women who stop running because they pee themselves. And when you dig into the research, which I have done, you see that between 40 and 60% of women either change or quit their sport because of bladder leaks. And honestly, that is 100% too many women in my book. And I get it. I went through a period of time when I had urge incontinence so bad, I would sometimes pee myself just trying to punch in the 4-digit garage code to get into the house after a bike ride. And I'll say right up top, though we talk about it a lot in the episode, vaginal estrogen was a total game changer there. I can't remember the last time that happened. Also, because of episodes like this, I have been working on relaxing my pelvic floor, which I learned is chronically tight. We all think Kegels, 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 but if you're way, way, way too tight, that's not the answer. We talk about that too. I was just really psyched to have this whole conversation with our expert this week, double board certified urogynecologist, Dr. Lauren Siff. We break down all of it, the difference between stress and urge incontinence, why athletes and active women are prone to leaking, and how the whole menopause transition can worsen the situation. And of course, we talk about the full suite of solutions from pelvic floor exercises and support devices to the role, yes, of vaginal estrogen and much, much more. Dr. Siff's message is loud and clear in this one. No matter how small or how severe your symptoms, there's help, and you never have to stop doing what you love. Dr. Siff is Chief of Gynecology and Urogynecology for the Central Virginia VA Healthcare System and Associate Professor at the VCU School of Medicine and VCU Institute of Engineering. She is a powerhouse in her field and a font of knowledge. I hope you enjoy this one as much as I did. Before we get to it, give us a follow at Feisty Menopause and Instagram, I should say at Feisty Menopause on Instagram and Facebook, and join our private Hit Play Not Pause Facebook group with 37,000 women strong to have these conversations around the clock. Thank you for your kind ratings, reviews, comments across all the platforms, YouTube, Spotify, Apple. I really, really appreciate it. Now closing out our 6th year of the show. It's hard to believe. And stay tuned. I have some special plans going into year number 7 that I think you're all really going to love. Lastly, don't forget to sign up for Feisty Fest. In case you missed it, Kate Verneau, the powerhouse behind Le Tour de France Femme avec Zwift, will be giving a keynote. Marley Blonsky will be with us. Our barbell coach, Cassie Neiman, will be there. So many of your feisty favorite guests and hosts will be there. I'll be live podcasting. There'll be clinics for running and swimming and lifting and pickleball and just about everything else you can imagine. So head into those show notes and get your ticket for September 18th through the 20th, and I will see you there. With that, enough of me. Let's have a few words about our awesome sponsors and get on with the show. All right. Dr. Siff, welcome to Hit Play Not Pause. Great to have you here.
Thank you. I'm excited. This is going to be a fun talk.
So the first thing I would love to hear about, because this is something that I am actually pretty naive on, is what actually is a urogynecologist? Like, how is it distinct from urology and gynecology?
That's an awesome question. So urogynecology is a subspecialty. You can come at it from either way, though. So everyone will go to medical school, pick what they want to do. They'll go to a residency. You could do that in either OBGYN or urology. And then after that, within each of those, you can decide, I want to be a urogynecologist, and then do a fellowship or a couple of more years for the training, especially for surgical management, but for really learning what the population is. And for us, it's managing kind of the umbrella term is pelvic floor disorders.
Mm.
But basically, that will be anything that causes symptoms of the bowel, bladder, sexual function, and kind
Okay.
of all of that is within that umbrella. And that's our focus.
This is another ignorant question. But if you were just a urologist, how would that be different?
There are people who feel like they get sufficient training as a general urologist who can offer treatment for some or all of those conditions, and can still provide non-surgery or surgery or anything. So you could still be a general urologist. You could also be a general gynecologist and still offer some of this management. We just have 3 additional years of
Which is
treatment.
not nothing.
Right. It's a long time. That's super focused and gets some of the nuances when you see like more complex things or this, all of that area. It's such a small real estate where so much is happening between the bowel, bladder, uterus, vagina, you name it, that usually if you affect the bladder, you're going to affect one or the other. And so some of the other systems. And so kind of figuring out how you can manage maybe all at the same time is part of the benefit of doing that extra training, I think.
Oh, I like that a lot. No, that makes crystal clear sense. Thank you for that clarification. So, urinary incontinence is just huge. It's huge. I think it's so huge that people just say like everyone they just expect it, right? They're just like, well, this is what it is. Um, and it's still like people talk about it a bit more in perimenopause and menopause, but I still feel like because no one likes to admit that they're peeing their pants or they're having these troubles, that we may not still have a handle on how common it is. From your perspective, how common is it, and how much does the menopause transition play a role?
So I would say a third to a half of women have some degree of urine leakage in midlife. Definitely, it increases in the menopausal transition. And, you're right. It's wild. People are happy to talk about their hot flashes. They're like, oh, I'm in my own personal summer over here. Like, no one's really kind of saying, like, oh, guys, look, my pad is so full right now. Like, nobody is talking about urine leakage like that. I mean, we're starting to see a little bit more with ads and commercials and some more conversation, but it really is more common than you think. And I'm glad there's a group like this that are willing to talk about it.
Well, really, I hear from women who stop their sport. This it becomes something really
Yes.
like I had a woman on who was, we talk about maintaining your power and doing plyometrics, and she did 3 box jumps and peed her tights. She's in the gym, and it's like, okay, like no mas, you're not going to do that anymore, or you're going to stop running. I know women who it's between stress and urgency. They're like, forget it. This is not happening. So it's a big deal. What patterns is stress or urgent continence more common than the other, or are they mixed? I mean, what does it really look like in real life for the women I'm talking about?
So I would say it's really good that you're even in tune to ask the types of leakage because this is actually hard for even doctors, even trained in women's health, to understand or just to really think about, I think. But just to get everyone on the same page that's listening, there's two main types or kind of three main types. It's crucial. There's stress incontinence, a leakage from some kind of stress on the bladder. It could just be a cough, a laugh, a sneeze, but in this case, jumping, exercise, any powerlifting, squats, like you name it, some kind of acute stress on the bladder, and that causes you to leak. So, I mean, if this is the bladder, this is the urethra where the urine's coming out. The really what it is like the pelvic floor. It's a support problem. So, some kind of a jumping jack, a lifting, your urethra is not supported, bounces, leaks. All right, that's the first type. Second type, urgency, frequency. Some people call it overactive bladder, but it's the gotta go, leaking on the way. Kind of that like keys in the door, feet on the floor, trigger, like I'm leaking. And those are more like large volume leaks.
Hmm.
So, what I'll say for this group is we know that athletes, particularly those doing powerlifting, especially CrossFitters, we know are more likely to have stress incontinence, like 45% in large systematic reviews show CrossFitters have stress incontinence first at younger ages and even without any other stresses like childbirth, pregnancies, etc. So we know that's the first thing. But then what we start to see with the menopausal transition is often you can see worsening of stress incontinence, mostly because there's estrogen receptors just like they're everywhere in the body. They're also in the urethra, in the bladder, and in the vagina. And so, yes, you see decrease of estrogen. You also see change in collagen types as you age. So the tissues are inherently made up differently and are weaker. So, yes, that pelvic floor is less supported and you leak more. But what we start to really see is kind of an introduction of the more irritative type symptoms, urgency, frequency, and the urge incontinence at the menopausal change. And what estrogen also does, interestingly, is it affects the pH of the vagina.
Mm.
And so the environment naturally will change as the pH changes. You're more likely to have bacteria naturally get in the vagina normally. That with the pH drop, you see a change in what kind of bacteria and good bacteria live there. Now, when bacteria gets to the vagina, it becomes a UTI. So we see people with increased UTIs, increased urgency, and all of this around the menopausal, perimenopausal transition. So we're kind of seeing both. And that's the mixed picture if you've got a little bit of both. And then in really one thing I would be remiss, I think, if I didn't mention for athletes is that if you're doing kind of overworking of the pelvic floor or of exercises or constant bracing of exercise, this is tons of core work or like very long races, long sessions when you're like holding constantly. It looks like you're a constant Kegel, right? Your body cannot relax and so subconsciously learns to have it challenge relaxing. So you may be the kind that is getting urgency, frequency, and even more like pain. Pain with sex, pain with sitting on a bike seat for long periods of time, pain after working out. So that's kind of another picture for athletes. So stress incontinence first, urgency, UTIs kind of stuff around menopause, and then that unique situation depending on your own personal activity level is and type of exercise could be that kind of high tone tense pelvic floor.
Yeah, I mean, I was nodding because I've said many times on the show, anyone who's listened for a long time has heard this, but I was a mountain bike stage racer, and we would hold it for hours and hours and
Yeah.
hours. And, like, I am still conditioned that as soon as I step off the bike, it is time to pee. Like, it is just,
Yep.
which leads me to, like, maybe a more nuanced question before we step ahead a little bit. I understand the stress part and the support and the tissue changes and the collagen changes. I'm not understanding as much what you meant by irritative. I mean, I understood the pH changes, but like, how is that contributing to this urge incontinence? And what else is there like with that, with what I'm talking about, there's definitely a psychological component that is happening here. But that's not necessarily a menopause or an estrogen thing. But what is happening with that key in the door and that urgency thing that I hear so many women once they hit the transition talk about it. And my own mom, who was not an athlete, would like just park the car and start running. I just remember her just running to like whatever bathroom she could find.
Yeah, and you know what's so this kind of urging kind, and some people call it overactive bladder, meaning just like you're not leaking, you're just going all of the time. It's interesting, and I think it's the thing we actually know the least about. And it's because over time, we've kind of just lumped everybody with these symptoms together. And that started out because we realized that, okay, well, medications or certain treatments help all of these people. So let's just kind of call it a syndrome. That doesn't really work. But now you're seeing research pop up on the different types of these. So people with triggers, like the key in the door and these sorts of things, they may have a different sensory type where they just process sensation differently.
Mm,
We may have people who have kind of that hypertonic pelvic floor, and that's the urge and frequency mostly because it's like a spasm of the
right.
muscles.
That might
And
be sending
then
a signal to your brain.
that sends a signal to your
Yeah.
brain, and it's just, and sometimes yeah, you're right, it just becomes in the subconscious signaling. And then otherwise, it's, I guess this whole group umbrella is under modulating the nerves to the bladder. So we don't understand nerves in many parts of the body, and I think the bladder is one of them. And so if you think about the nerves to the bladder causing this urgency, the way that that gets triggered is different for different people. Um, some of them are clear bladder irritants that we know. This is like caffeine, alcohol, spicy food, citrus, right? Same things that people who talk about having like an irritable bowel syndrome, it's kind of like an irritable bladder syndrome. But we also know that stress levels really set this off, inflammation in the body set this off. And so those also increase with menopause. I don't need to tell you or anyone in this audience that. But like those also increase with this transition. And so we see kind of a multifactorial effect on the nerves to the bladder that cause this urgency frequency type of picture.
That's so interesting. And it is, I see two of my worlds merging sometimes. Like before a race, I will literally, I'll pee, I'll open the porta potty door, and then I'll close it again. Because I'm like, I think I
Yes.
have to pee again. I think I'm not done. But like I have that happen just when I'm under stress in my house sometimes. So there's definitely something happening there.
My office gets full and has a lot of phone calls around get it Maycember when schools are getting out, people with kids who are in school and under a lot of stress, like constant activity around the holidays when they're under a lot of stress and they're having to like see family members, like psychological stress, physical stress, like, or people that are in training, athletes in training. And so we see that all the time.
Yeah. Is this all like what role are you more susceptible, I guess is what I'm asking, if you have also had children?
You are. Um, you are because for a couple reasons, and that could affect both the nerves because just being pregnant compresses the nerves. Having a vaginal delivery also affects the nerves to the bladder and vagina. You are also more likely because it changes the strength of the pelvic floor muscles. And so you may see pelvic organ prolapse. People say, oh, I feel a heaviness or a pressure, my bladder's dropped down, like these kinds of symptoms. So pregnancy alone or vaginal deliveries would increase both the nerve component and the muscle component. So you could have either of those be worsened.
I'm curious. It feels like you can have these, stress, urgency, mixed incontinence without having any prolapse sort of issues going on, clearly.
Yes.
They seemingly would exacerbate these issues if you also have those issues going on. Do women know when they have a prolapse? That seems like a silly question, but it seems like maybe they don't.
I think it's a good question because prolapse, often I hear people describe is like all of a sudden one day I was sitting on the toilet and out comes my vagina, like out of my vagina looks like I'm laying an egg, like there is a pink ball of tissue and I push it back in. Like that's clearly to me, that's definite prolapse.
Yeah.
Other people, though, we know that it doesn't happen all of a sudden. It's not
Right.
like, okay, today I hit a PR and I lifted higher and everything fell out. Like that one lift was not the cause. Over
Right.
time, this happens. You see a slow descent, you see a change in the tissues, but you don't feel it until it hits right at, we call it like point zero on a measurement system of the hymenal ring or right at the opening of the vagina. And that's when you'll feel it. And so this could be happening all along. And then whatever happened the one time, you now feel it. And it
Yep.
comes and goes because if you're standing all day or you've had a day where your workout is a lot of pressure on the pelvic floor, you feel it more at the end of the day. And then you go to bed, you lay down, you relax, it goes back in. So we see kind of people who say, I feel it, I don't, I feel it, I don't, that kind of thing.
So many women, as I started in this conversation, will just assume not what you're just talking about, but just like the leaking, oh, I pee when I sneeze. Sometimes I can't make it to the bathroom kind of thing. Just like, oh, my mom was like that. Oh, it's just part of being a woman. Oh, whatever. But tell me if you have that starting to happen, should you seek care when that starts to happen?
You know, this is a key point is that leakage and bladder symptoms are a spectrum.
Okay.
So it can be small, occasional leaks, like only when I am on a trampoline or only, like that's the only time and it's a little bit of leakage all the way up to I'm constantly soaking through like pads, clothes, etc. at any age. And it's not like a natural progression from one
Okay.
to the other either. And
Okay.
so the most important thing about when you should seek care is the idea of like the amount of bother it's causing you. So, the good news is it's not life-threatening, this condition. But it's totally life altering. And if it's bothering you, that's when you seek care. So if it's affecting your sleep, now you're not sleeping, you're waking up, changing your sheets, like you're self dehydrating, you're stopping your exercises, you're avoiding sex because you are afraid you're going to leak or be in pain. Like those are the times you want to seek care. I kind of tell people, like, it's never too late. I mean, if it bothers you at 90, like, you're not out of options. And if it bothers you just a little bit, at 25 at a CrossFit competition, like, also we can give you choices for that. So you can
Right.
kind of see anything there.
But I also heard, which I appreciate, that because you have this thing that is happening, sometimes you're not on this immediate slippery slope. That
Right.
right. Those are good. That is good to know. And I'm sure we'll talk about this, but one of the things that can kill you is a UTI, right? Like if you are getting if these things become associated with UTIs, this is a problem.
Yes. We know that the good news on that front is prolapse itself does not cause UTIs.
Yep.
So stress incontinence itself does not cause UTIs.
Yep.
With overactive bladder, same with really even like holding it doesn't cause UTIs in and of itself. But if you're sitting in wet pads all of the time and like then maybe yes. But to the point earlier, the change in the vagina, the change of the pH of the vagina with a drop of estrogen will cause UTIs. And that is why we start to see people around the time of menopause all like I never had UTIs in my life or like maybe in my 20s and now it's constant. I can't get rid of it. It's like 6 times this year. That is important to see. And in fact, I don't know if this is right or wrong, but the medical community deems someone in menopause with recurrent UTIs, repeat UTIs, like 3 in a year, 2 in 6 months, complex just because they're in menopause. So, yeah, I know. And so you will then kind of get a little bit more of a workup, a little bit more of a focus. It's different that than someone who says, every single time I have sex, I get a UTI the next day. And that's like a very different, um, a very different thing. And so it is important. And the best news is usually vaginal estrogen creams is like the key here. And how easy is that to do? So, and we can talk more about that as however you guys want, but that is the best prevention.
Yeah, and that's a good segue because I'd like to segue into talking some solutions. And where where do you start? If I come in, what are your first questions and how do you approach care?
So for me, it's truly figuring out what kind of leakage you have. So going through really just listening. It's hard for anyone to do, but like tell me what bothers you and how long it's happening and what you experience. Tell me what's going on. And then it's asking some of the simple things like, do you empty your bladder? Do you have neurologic conditions? Like, kind of ruling out some of these more serious things, right? A neurologic history of stroke, multiple sclerosis. Like, these are things that we do need to make sure are not a culprit. Um, do you feel a bulge in the vagina? Do you have constipation? Like the range of symptoms. You tell me what you have going on. Tell me how much it bothers you. I generally also, people often come in knowing what they want to do about it, or tell me your experience. Like, my sister had a horrible experience with XYZ. I definitely don't want that. Well, that's super good for me to know. And then usually to follow that is a basic pelvic exam. And feeling for cysts, feeling for problems with the urethra, with the vagina, any prolapse, that kind of thing. I usually do check that you empty your bladder. Sometimes we use tiny catheters for that. So what we do is we have you go to the bathroom, urinate normally, and then we check how much is left. So either with a tiny catheter in the bladder or a quick ultrasound that'll give me a number of how much urine is left in the bladder. And everybody has some left in the bladder. There isn't exactly a hard and fast rule, but oftentimes we kind of use the idea of like 100 cc's or like one of those little urine cups full is normal. And above that, I start to kind of like want to know more, raise my eyebrows, think a little bit more about it. So I check.
What are you looking for there? And are there changes that happen that lead to it being more difficult to empty your bladder?
Yes, if you have a neurologic condition or damage to your nerves, in this case, sometimes people with back injuries. So over time, hip, back, other injuries can be from overuse, from exercise, or from, just some kind, like you'll get a slip disc. We see this a lot, right? So any back, hip, etc. issues, the pelvic floor can respond and be tighter. Same with all of the things that we talked about earlier that make your pelvic floor tight and you can't empty. That's one. But also the nerves to the bladder come from the spine, and we always say like S2, 3, 4. A sacral level 2, 3, and 4 keep the bladder off the floor. Like that's the little tagline. But those are the nerves to the bowel and the bladder, which come out a little bit higher. So people are like, oh, I have an L4-5 disc injury. Like these kinds of things can lead to your bladder not functioning, a nerve damage to the bladder, something like that. Also, if you have prolapse, let's say, again, the picture of the bladder and the urethra, the bladders drop down, it kind of is kinked off from the urethra, and so it cannot empty all of it. Those are the big causes of a non-emptying bladder. And with urine sitting in the bladder, you'll have more urge, you'll have more frequency, you'll have more risk of UTI.
This is I don't know what kind of question this is, but You know how people use the squatty potty to make sure that they evacuate? Like, is there any help for peeing?
This is really great. Some people, if you have prolapse, then you may also call it splinting. You can do it for the bowels or the bladder, but you might put a finger inside the vagina and support the bladder. If the bladder's dropped down, you push it in a little bit so that it empties. You could do the same on the bowels. You push down a little bit, or you can even just push pressure on the perineum with your hand, like that area between the vagina and the rectum. You just push pressure to help empty. That's one. Some people simply lean forward and learn a position that helps them. That's for prolapse people. If you are someone who is one of the high tone people that has trouble emptying, doing some of the relaxation exercises to consciously open the pelvic floor, even some like quick box breathing breaths, like breathe in, hold, breathe out, and focus on kind of opening the pelvic floor, that in and of itself often helps enough to initiate both bowel and bladder.
Yeah, that's interesting. I still have that, and I'm going to try that.
Yeah.
Because I know that I don't fully empty sometimes, and I suspect it's because that I've been holding for half of my
Yes.
life.
Yes. I mean, your body literally, it's just like, okay, I don't worry about not emptying because I'm going to keep holding like I've been doing. But yeah.
Yeah. So then, what other tools are on the table for stress and or urge as far as incontinence is concerned? Are we going straight to, pelvic floor therapy where they're doing certain exercises or using tools to sort of help release, you know, tension or, where do we go from here?
So I'll break it down. We'll start with the stress incontinence side. So on the stress incontinence side, it's really if it's the pelvic floor is the issue, then the answer is addressing those muscles. So either strengthening exercises like pelvic floor physical therapy. Some people do it on with a pelvic floor physical therapist. Some people do it on their own. There are plenty of um, digital resources that help folks too. So this is one. The next is some kind of support device that physically goes in the vagina and just pushes up to provide the support that's lacking.
Like a pessary.
Like a pessary, which is a silicone ring, but not just any pessary. The plain rings hold prolapse in, but the rings with a knob, that little area that will sit underneath the urethra will provide the backstop from the leakage because
Oh.
the weakness is generally under the urethra for stress incontinence. So that's one. But and you would go see a doctor to get these, a gynecologist, a urogynecologist, some urologists. But you can also use a regular tampon. You can use, there are tampon brands that are specific for leakage that you can get out there. They're shaped more like a pyramid, so they have kind of that larger part at the opening. For people that leak only with long runs or only with like high intensity training, they'll often use one of those devices just during the training. They don't leak any other time. They don't need it any other time, and that works. Um, we also have, so it's kind of like pelvic floor PT, muscle training, support devices for support, or surgeries. And there's an office procedure where we literally bulk the urethra. People are sometimes more like think about it as fillers. It's not like a filler, if you will. But if this is the urethra, like a circle, you take a look inside with a camera and inject in the large circle 4 tiny cushions of, in this case, I use kind of a water-based gel, and it closes the urethra from wide open like a hose to kind of a smaller area. You can do those in the office or in kind of a surgery center. And then there are also surgeries like a sling procedure people have heard about, which is a ribbon-shaped piece of mesh material that's just placed under the urethra to provide the support by scarring into place there. So that's all things stress incontinence. And actually, I actually did a study as a fellow on commonly performed exercises that and how they affect the pelvic floor. And these were in women right after they had in the postpartum period, so within the first 6 to 12 months actually after delivery. And we had all these women come in. They came in on a Saturday. I worked with a postpartum doula, a yoga instructor, and a couple of urogynecologists, and we had people do all of these exercises, and we took measurements both with a device that went in the vagina and measured how much pressure you're generating, as well as ultrasound to look at the shape of the opening. And we found out that people who were doing exercises like bird dog, leg lifts, planks, those actually affected the pelvic floor very similarly to a Kegel. So people say,
Hmm.
okay, yeah, I do Kegels. I don't know what to do. I can't tell if I'm doing them right. Like these are exercises that also work. And then we also saw things like clam, or we saw actually bridges and other things open the pelvic floor. And so if you're on the side where you really need to relax the pelvic floor, these are exercises that may be more familiar than trying to kind of like consciously do these things.
Like a
So,
clamshell
yeah,
or
like you're
something.
laying
Yeah.
on one side and you have one leg that
Yep.
you lift up and put back. Yep. Um, so that's on the stress side. On the urgency side and on the stress side, the good news, I kind of tell my patients, like, the world is your oyster. You don't have to go in any certain order. So if you came and said, listen, I absolutely love running marathons and I can't do it anymore because I'm leaking, and you say, I want this fixed like completely forever, it is not unreasonable to go straight to surgery and have a sling. Like that's
Right.
totally fine. It's what you want. Or if you say, I am not interested in surgery, how can I manage this? And I can give you those options.
You can also manage pressure just before we go to urgency. I've talked to some people who are power lifters who manage their pressure with their breathing too. Like as far as
Yeah,
like how much they're bracing, when they're exhaling.
that's right.
Yeah.
Yeah, that's a really, really excellent point. And one that I actually don't want to miss out on because I don't want people, especially this audience, to feel like leakage is like a sign of somehow weakness. Just because the pelvic floor is weak, you're like not weak. In fact, usually it's our power lifters, as you mentioned, but it's not just about strengthening the pelvic floor, because to your point, over strengthening is not great either. It's really about the timing. So it's timing, it's coordination. So if you
Right.
do go to a pelvic floor physical therapist or work with someone in person, they can actually help coordinate the strength so that you're not doing a Kegel when you don't want to, like sitting on the toilet. You're doing it when you land on a jump or when you are increasing pressure with lifting. So
Right.
that's exactly right. So thank you for calling that out.
Yeah. Excellent. So then you were going to go to
Yeah, the
urgency.
urgency. Let's talk urge, and kind of what our options are there. This is one that we take people down a care pathway, and we tend to do it in order.
Okay.
So the first thing is conservative measures, and this is more lifestyle changing. So this is managing your fluids, and I never tell people to like drink less than XYZ or drink this many ounces. That's not what I mean. I mean, spread it out consistently throughout the day. So you can drink as much water as you want. I just don't want you like chugging a ton in the morning, then nothing all day, and then a bunch at lunch, and then nothing all day. Those are shocking the bladder. So try to just keep it a few ounces or however much you drink per hour. Same thing on the voiding front. We want you to void consistently throughout the day. Every 2 to 3 hours is kind of a normal cadence. Um, but some people don't have the urge because they've held it all their life. So I say go sit on the toilet every 2 or 3 hours. On the flip side, people who say, I'm already going every 30 minutes. Well, you can train the bladder. The bladder is a muscle also, and you can train it just like you can train anything else to get stronger and hold more. So you go every 30 minutes, meet you where you are, go every 30 minutes for a week, next week every 45 minutes, the next week every hour. I mean, just like you're increasing your weightlifting, your bladder's increasing its strength. So, same concept. So, you've got that sort of thing. And then I tell people there are some common triggers, and this is more on the nutrition front. There are some common triggers. We talked about caffeine, alcohol, spicy food, carbonation, sugar substitutes, citrus. People are like, oh, I drink, lemon in my water all day long. These people have a lot more urgency. But I also kind of say, like, again, this is quality of life. If someone told me not to drink caffeine, like, or coffee, there's zero chance I would ever do that.
Zero, none.
I would just rather like go more, like
Yep.
urinate more, wear a pad, whatever. So you see what makes sense for you and then adjust that to your life. But I also don't drink sparkling water on a road trip. Like those are kind of things I can do.
Right.
Step 2, medications. And these are all the medications that you've probably seen on commercials. They're all the same. Detrol, Ditropan, Vesicare, they're all the same. There's really 2 classes. One has a bunch of side effects of dry eyes, dry mouth, constipation. The other you should not be taking if you have things like high blood pressure and that sort of thing. So you can kind of work in your individual situation, figure out a medicine. And then there are also procedures. Procedures being a Botox injections to the bladder. I always kind of thought like the same thing for like wrinkles. Like, oh, it tightens your face. It does not tighten, it relaxes. The same thing in your forehead or anywhere else. It relaxes. It relaxes the bladder, Botox. So it's not squeezing constantly. You're not having the urge. And then there's also bladder stimulators. These are like a little pacemaker placed in the buttock to the nerves to your bladder, or we even have some that are in the ankle. So, tons and tons of options. You go with what makes sense for the severity and the degree of bother for you. And then honestly, some people, they have a bunch of nighttime leakage, and that's when I start to see them because to your point, perimenopause, you're already getting sleep disturbances. So now some people are like, oh, I don't even, I can't tell if I'm waking up and then just going because I'm afraid that I'm going to wake up again, or is it the urge that's waking you up? And
Right.
some people I've actually seen say, I'm not even waking up anymore, I'm just leaking. And I
Wow.
wake up in my sheets are soaked, or people who've had an injury, like an exercise injury or a surgery, hip replacement, shoulder replacement, these kinds of things. They aren't getting up. They can't. It's painful to get up. And we actually have people you can use management systems for these things. So, reusable underwear, so you don't feel like, you're like, I'm 50. I'm too young to be wearing diapers, right? Like, so we have reabsorbent underwear. People joke, they're like, I just want a catheter so I can sleep all night. All right, you don't want a catheter,
No.
right? But they actually are some systems you can use. We have like it's kind of actually hospital grade. You can use it in your bed. There's suction systems. And for your group, probably more like in recovery of after an injury or something like that. But where you really are having difficulty or you just don't know, you're getting up. And instead of the catheter, this is kind of like a comfortable cushion that sucks away the fluid. You don't have to get up. It's called a PureWick system, and you can get them for your house. So those are other things. So you've got the management systems of the symptoms, and you've got all the treatment options.
Outstanding. Where does vaginal estrogen fit into this picture?
I should have said that first. That's for everybody. I give it out like candy. So everybody comes in, they walk out with it. And,
It
and I'm
helped my urge incontinence, I can tell you that.
100%. It helps. It helps urge. It, honestly, the best thing that could have happened earlier this year. The FDA removed the black box warning on vaginal estrogen, so people don't have to read what's antiquated, inaccurate that says like you're going to get strokes and heart attacks and blood clots and breast cancer. None of that's true from vaginal estrogen. And it is super helpful. We mentioned UTI, super helpful for urge, pain with sex, vaginal dryness, It doesn't fix or treat stress incontinence, but the tissue is healthier. So if you
Hmm.
are undergoing a procedure or a device or something like that, it can also make the quality of the tissue better. And there's 1 million different types of estrogens you can do. Um, I think for people with urge symptoms or UTI symptoms, using just like a pea-size amount of cream on their fingertip rubbed right at the opening of the vagina in the urethra is helpful. Creams come with an applicator, and I just think it's kind of messy. It's a waste. People don't want to do them. And so if you just have to use just a pea size on your fingertip nightly, if you forget it a night or two, totally fine.
Yeah.
I highly, highly recommend for everybody.
Yeah, and do you ever get into DHEA for any of that?
I don't usually use vaginal DHEA for that, but you can. You can. And in my training, some people were. Um, if there's no contraindication for vaginal estrogen, which, as we mentioned, there's very, very, very
Yeah.
few, vaginal estrogen is most effective.
Yeah. Excellent. Well, this has been outstanding. Is there anything that we have not covered that you wanted to make sure that we did cover?
I think the most important thing, um, well, I will say one question that I liked that, in thinking about this ahead of time, I had read from you was really like, if our listener hasn't told anyone or is experiencing these symptoms, like, what do you do? I loved that. So I don't want to forget to say that. Take a little bit of an inventory of what's happening for you. And when you're experience people, I think when you say the word like write a diary or a journal, it has like a bad connotation, like nobody wants to do that. But just keep like a little bit of a log of what's happening for you and when it's happening and how much it bothers you. And then,
Hmm.
honestly, if you can think of a goal for treatment, not necessarily, you don't have to remember everything I just told you, what your options are, but like how you would want to feel, or if I could help you with one. If I could do this one thing for you, it would change your lifestyle. Um, that is super helpful. And then you can see a urogynecologist without a referral, just so everyone knows. I really love the site Voices for PFD, standing for pelvic floor disorders, but voicesforpfd.org. It's from the American Urogyne Society. There's a lot of the same information that I gave you. You can focus on what is your individual symptoms. You can look through, you can ask questions. And they're manned by your gynecologist. Sometimes I'm answering those questions or my colleagues are answering those questions. And we can help guide you and you can also look at the very end, I should say, it'll say, find a healthcare specialist in my area. You just put your address and how far you want to look, and they will tell you pelvic floor physical therapy, a urogynecologist. And sometimes, of course, you can ask your primary care doctor. They're familiar with a lot of the medications. They're able to get you some of the devices like the absorbent underwear, the PureWick. They're able to help you get these things, but you can also go to a urogynecologist without the referral that way too. And I just want you guys to be equipped with all the tools you can.
I appreciate that. This has been really enlightening and very, very helpful. And we will put all the links to how to find you and those resources in the show notes. What I'm hearing is that no matter what your situation is, that there is help to be had.
There's help to be had. And please, whatever you do, don't stop your sport. Please. Oh my gosh, you guys are incredibly amazing and strong. And when you're distracted by embarrassment or worry, your performance is always going to be worse and less enjoyable. So let us help you make the most of what you're already doing amazingly.
Well, that is our show. Come on back next week when I sit down with OG Peloton instructor Jen Sherman, who has recently shifted her focus to what she calls the back nine era, redefining strength, Longevity and Fitness for Women Over 50. It is some seriously good stuff, so come on back for that one. And until then, as always, stay feisty. You have been listening to Hit Play Not Pause, a feisty menopause podcast for active performance-minded women. I'm your host, Celine Yeager. The show is edited and produced by the most amazing Carrie Barrett and the other talented, strong women at Feisty Media. Follow us on social media at Feisty Menopause, and please help us spread the word. Screenshot and share this episode on your social media channels with the tag @FeistyMenopause. And please subscribe, like, review, and rate this show wherever you get your podcasts. Word of mouth and good reviews make it easier for other listeners to find. Thanks for listening, and as always, stay feisty.